patient will need to have a pacemaker, and there is a full range of pacemaker. Pacemakers are not only meant for slow heartbeat, but there are some devices that we implant for patients who are at risk for cardiac arrest. So here in the CVSKL, we implant from the latest pacemaker, which includes the leadless pacemaker called the Micra. Normally, the pacemaker will be implanted using a small incision at the chest, and a wire is implanted. But for the latest technology, we implant the pacemaker without using wire and without having any surgical. It's just going through the legs. This is the range of all the pacemakers and ICDs and CRTs that we have. So here, if a patient has slow heartbeat, we implant a pacemaker. If the patient has got at risk for cardiac arrest, we implant an implantable defibrillator. What does it do? Implantable defibrillator gives an automatic shock to the patient when the patient has a cardiac arrest, and hopefully that will be able to resuscitate him. When the patient has heart failure, we implant a device called resynchronization therapy. We try to resynchronize back the heart failure and improve the heart failure. The full range of EP services also include for patients who are at risk for stroke and they cannot take anticoagulants, blood thinners. Here at CVSKL, we implant the left atrial appendage occluder, and we are very experienced in implanting the Watchman device in this hospital. I hope you enjoyed your virtual tour of our facilities here at CVSKL, where I have the pleasure of showing you around my EP lab, the kind of things that we offer at CVSKL, the full range of ablation procedures, the full range of implantable devices. I hope, perhaps I better not say I hope to see you all here. I hope not to see you all here, but if you do need our services, you know where to come. This is one of the best facilities in the region. With that, I would say adieu, bye-bye. But today, I would like to focus this live session on a very special topic, very close to my heart, which is atrial fibrillation. Now, atrial fibrillation is a very common condition. In the last 5 years that I've been at CVSKL, I have seen more and more patients presenting at younger and younger age with atrial fibrillation. Previously, atrial fibrillation used to be affecting more older patients, such that if you are 75 and above, the chances of you getting atrial fibrillation is 1 out of 10. So in a room of 10 75-year-old and above, one of you probably will have atrial fibrillation. But that has changed over the last 5 years. We don't know why this changes. Number one, there are more and more people getting atrial fibrillation every year. This has been established not only in Malaysia but the rest of the world. Number two, we are seeing that atrial fibrillation now occurs in younger and younger patients. So that's very disturbing. So what is atrial fibrillation? So let me answer the first question. What are the general signs that I should look out for in atrial fibrillation? Now, if atrial fibrillation has got some symptoms, it is much better for you. Why? Because the symptoms leads you to go and see your doctor. But in half the patient, they have atrial fibrillation, but they don't have any symptoms. That is more worrying. Why is it worrying? Because if you have an silent
asymptomatic atrial fibrillation and you have risk for stroke, then you may get stroke first. Until you get a stroke, then the diagnosis of atrial fibrillation becomes apparent. So it's very, very important for us to be able to now discuss, at least in the next few minutes, what are the symptoms of atrial fibrillation that you can look out for. Generally, the symptoms that is most apparent is palpitations. Palpitations mean the patient feels the heartbeat is unusually fast. Now, our resting heart rate is between 60 to 100 beats per minute. Resting heart rate. Of course, when you do a bit of activity, when you hear a disturbing news, your heart rate will go up even though you are resting. In atrial fibrillation, which is untreated, the heart rate usually is above 120 beats per minute. So if you are sitting down watching TV and then suddenly your heartbeat goes above 120 beats per minute, then you have an arrhythmia. It's called tachycardia. Tachy means fast, cardia means heartbeat. So fast heartbeat. Now, one of the simple ways for us to advise patients is to feel the pulse. So there was a short video that I did when I show people how to feel the pulse. So if you have to try and train to feel the pulse. So we used to teach people to feel the pulse. But nowadays there are smart watches that are able to even better than feel the pulse because it can detect atrial fibrillation. Again, we don't want to be too commercialized, but smart watches like the Apple Watch, the one I'm wearing now, is able to detect atrial fibrillation automatically and alert the wearer that you may be in atrial fibrillation. And the good thing is that you can then even do an ECG on your Apple Watch. Now, those of you who have Android, don't worry, because Android watches like Samsung and Huawei, from what my patients tell me, also can have the ability to detect atrial fibrillation automatically and alert the wearer, and also you can do an ECG. So, if you ask me, how should I look out for atrial fibrillation? Well, for those of you who are at risk, and we'll talk about the risk later, and you have a smartwatch on your wrist, then if atrial fibrillation were to appear, then you might be alerted. I have patients that have come to see me, and they tell me they have atrial fibrillation, and I ask them, what are your symptoms? And they tell me, I have no symptoms. I do not even realize that I have atrial fibrillation until my watch alerted me. So, and yes, when I saw the ECG, and later on, subsequently, we confirmed the diagnosis of atrial fibrillation. So that patient was, in a way, saved because his smartwatch was able to detect atrial fibrillation, and he received treatment before he gets any complication. So apart from palpitations, what else can atrial fibrillation present with? Some patients, they present with shortness of breath. So imagine you are doing some activities, your heartbeat is like say 90, 100 beats per minute, you are doing a bit of housework, suddenly it jumps up to 170. It's as if you are running, like very, very 100 meters. So of course the patient will suddenly feel that they are breathless, they might feel a bit dizzy, or they might even feel like they want to black out. So palpitations, shortness of breath, dizziness, or even blackouts, these are some of the symptoms. Sometimes, as I said, tragically, the patient presents with stroke, and we don't want that. Because when a patient presents with stroke, then it's probably too late, because stroke from atrial fibrillation is different from stroke from other causes. Because imagine a blood clot is like an asteroid that hits the earth and it destroyed the dinosaurs, right? So it's the same thing. The blood clot in your heart travels to the brain. It damages a large portion of the brain. So the stroke you get from atrial fibrillation is far worse, far more debilitating, and a lot of patients are left with a long-lasting, some form of neurological deficit. And of course, 20% of the patients die with a stroke. So we don't want that. Number two, atrial fibrillation can lead to heart failure. What sort of atrial fibrillation leads to heart failure? When the atrial fibrillation is undetected, uncontrolled, and the heartbeat is persistently very, very fast. And the patient goes about his normal activities. Even some of my patients do marathons, and they don't realize that the heart rate is so fast, and they push themselves, they do marathons, and the heart rate is consistently above 180, 190, and this leads to weakening and heart failure. And the patient sometimes collapse because of heart failure. So these are all the signs and symptoms that you look out for atrial fibrillation. As I said, 50% of the patients do not have any of these signs and symptoms. So feel the pulse, or some people during the COVID era, I realized how important it is to be able to detect with your home appliances. You know, during the COVID era, a lot of us were using our pulse oximeter because we are so worried that when we get COVID, our oxygen saturation comes down. And the pulse oximeter also tells you about your heart rate. So some of the patients say, you know, I was watching my oxygen, suddenly I noticed that my pulse oximeter showed my heart rate was so fast. And then I later on realized that it was indeed atrial fibrillation. So pulse oximeter, simple way, very cheap, you can buy online. Blood pressure monitoring, people who monitor their blood pressures, certain blood pressure sets are quite good. They can detect atrial fibrillation and they will tell you ARR, means arrhythmia. So if you have, while you're doing your blood pressure and the blood pressure sets detects irregular heartbeat, it may alert you and say ARR. So these are all the things. So feel your pulse, pulse oximeter, blood pressure set. For those of you who can afford it, then get a smartwatch. All these things will be able to perhaps detect for those of you who do not have symptoms of atrial fibrillation. So I've talked about the number 5 question and a bit about number 6, right? The type of screening tests I should do for atrial fibrillation. Are there any assessment that can be done to prevent atrial fibrillation? Well, if you look at what are the causes of atrial fibrillation, and perhaps we can try to see what we can do to prevent the onset of atrial fibrillation. There are many causes of atrial fibrillation, unfortunately. Atrial fibrillation sometimes is a product of certain conditions. For example, if you have we talk about age, right? And there's nothing you can do. All of us are going to grow old. So age is something we can't avoid. So aging leads to atrial fibrillation. But other conditions, like for example, hypertension, high blood pressure, very common in Malaysia. If the blood pressure is not well controlled, this leads to the left ventricle, your left bottom chamber, becoming thicker and thicker. And this leads to stiffening. And this then transmits the pressure to the left atrium, and this causes stretching of the left atrium, which triggers atrial fibrillation. So other than hypertension, diabetes can also cause the same problem, the same pathophysiology. Patients who have coronary artery disease, heart attack before, heart failure, and patients who have sleep apnea syndrome. Sleep apnea syndrome is something that is quite common. Patients who sleep and then they stop breathing, and because of that they do not go into rapid eye movement, no REM sleep, and this then consequently leads to left ventricular stiffening and again atrial fibrillation. Others, like alcohol, for example, too much alcohol, overweight, patients who are maybe long distance athletes. Again, I'm not saying that long distance, you shouldn't do long distance or all this marathon running, but if you compare those who do a lot of sports, endurance sports, the risk of atrial fibrillation is slightly higher. Not very high, but slightly higher compared to those who don't do endurance sport. Reversible causes, for example, young ladies with thyrotoxicosis, they can get atrial fibrillation, but that is usually reversible. Once the thyrotoxicosis is treated, the atrial fibrillation goes away. If you have chest infection, pneumonia, and sepsis, all this can lead to atrial fibrillation. So there are 2 types of atrial fibrillation. One is triggered by infection, thyroid, and this usually goes away once you treat the primary. And the next one is when it is there to stay. If you have hypertension, diabetes, and coronary artery disease, we can't cure it. We can only control your medication with medication. So if you don't control this primary risk factor for atrial fibrillation will come. So one of the ways for us to reduce the chances of getting atrial fibrillation is well-controlled hypertension, well-controlled diabetes, exercise regularly, lose weight, and then reduce your alcohol intake, and then basically lead a healthy lifestyle. So the same lifestyle approach to reduce coronary artery disease, to lead a healthy cardiovascular health is also the same to reduce the risk of atrial fibrillation. Unfortunately, even though you lead a good lifestyle, you run marathons, you don't smoke, you don't take alcohol, you can still get atrial fibrillation, but it is not as high as those who don't control their risk factors. So that's about atrial fibrillation in general, in terms of the symptoms, in terms of how we can detect it with our everyday day-to-day devices that you have at home. We talk about pulse oximeter and your blood pressure sets, and some people have smartwatches and also cardiac. So let me go through some of the other questions. Number 7, for example, my heart beat very fast when I drink coffee. Will this lead to palpitation? So coffee itself do not cause atrial fibrillation. So you have to differentiate between the cause and the trigger. If you have atrial fibrillation, for example, and you drink coffee, does it trigger more atrial fibrillation? Well, most people will be advised by their doctors, if you have atrial fibrillation or any form of fast heartbeat, any form of arrhythmias, maybe you should cut down on your caffeine. I don't like to tell my patients, you cannot take this, you cannot do this, because when you say yes and no, there's no gray, the patient usually will not follow you. So my best advice is, I always tell my patient, if you have palpitation, when you take 1 cup of coffee, do you feel bad? They say no. Do you realize that when you take the 2nd cup of coffee, you then start to feel palpitation? They say no. Go ahead and take 2 cups of coffee. By the 3rd cup of coffee, which is me today, this is my 4th cup of coffee. If by the 4th cup of coffee, you say my heart starts to become a bit fast and irregular, then that's your answer. Don't go beyond 3. Okay, so same thing. Alcohol is a bit different. If you have atrial fibrillation, then perhaps alcohol intake becomes more critical than coffee. So I always tell my patients, if you have atrial fibrillation, confirmed atrial fibrillation, you may want to think about stopping alcohol altogether, or at least cut down the alcohol to 1 or 2 units per week, not per day, per week. Can I see the some more question? Right. Okay, so that's coffee. So I hope I've answered the question on coffee, and I also added on a bit about the alcohol. Does AF run in the family? Generally, no. The atrial fibrillation in general is not a hereditary condition, although there are reports, very rare, of familial atrial fibrillation. That means that if you present with atrial fibrillation at a young age, teenager, your brother's got atrial fibrillation, your father got atrial fibrillation, so those have been reported but extremely rare. In my experience over the last 30 years of managing atrial fibrillation patient, I have not seen. I've just seen 1 patient where the father had atrial fibrillation at the age of 70 and the son got atrial fibrillation at the age of 19. So, but it was too far apart. For it to be familial, it has to be the father got it when he was 20 years old and then the son got it at 20 years old. So in general, in general, atrial fibrillation is not hereditary. If you have atrial fibrillation, don't worry, you're not going to pass it down to your children. So, are there any dangerous risk factors if AF is left untreated? Yes, I mentioned it just now. If you are of certain age, 65 and above, age alone, 65 and above, and you do not have any other medical condition, your risk for stroke is 1% every year. Now, people may say, 1% is so small, 99% I won't get stroke. What does it mean by 1% per year, annual risk stroke? Meaning that if I start year 0 with 100 people, at the end of the first year, 1 of the 100 gets stroke, right? Because 1%. Means when I enter year 2, I don't start with 100 people, I start with 99. What is 1% of 99 is more than 1% of 100. So at the end of year 2, you have another guy got stroke, right? So now you start year 3 with 98 and so on and so forth. So when they say 1% annual risk, it is not 1% lifelong risk, which means that if you live up to 10 years, then your risk for stroke becomes higher and higher and higher. So therefore, it never goes away. So that's very important that you must know this, even though when you look at the numerical value, when the doctor tells you your risk for stroke is only 1% per year, it is 1% annual risk. So let's, maybe we can take question number 10. Can AF be treated only with medication? Yes, certainly. Once we have confirmed the diagnosis, so the minute you have been told you have atrial fibrillation, and the diagnosis of atrial fibrillation is by a 12-lead ECG or Holter monitoring, but of course nowadays with smartwatches, and then the first thing doctors like me will do is we do a risk assessment. We look at your age. We look at whether is there any reason why you have atrial fibrillation. we will do a simple test like echo, ultrasound of the heart to measure the thickness of the ventricle walls, whether you have left ventricular hypertrophy, what is your heart function, is your valve working or not, is your valve damaged, is there leaking of your valve, is there a narrowing of the valve. All these are important. We measure the size of the left atrium. Then we come to conclusion. We will sit down with the patient. We say, sir, madam, you have atrial fibrillation and you have these reasons. We need to treat all the reasons that cause atrial fibrillation, and then at the same time we have assessed and analyzed that your stroke risk is 1, 2, 3, 4%. The first thing I'm going to do is I'm going to add on an anticoagulant, a blood thinner, and this is a very important treatment regimen. And some of my patients say, but doctor, I am already on blood thinner. And I say, which one? They say, I'm on aspirin and I'm on clopidogrel or Plavix. So I tell the patient, these are blood thinners, but they are antiplatelets. There are two types of blood clots. One is platelet rich. Those patients with coronary artery disease, blockages, heart attack, that is because of blood clot which are platelet rich. So you give antiplatelets like aspirin and clopidogrel and prasugrel and Brilinta. However, atrial fibrillation, the clot is not platelet rich, it's thrombin rich. Therefore, if you give antiplatelet, it's not going to prevent the thrombin rich stroke. So therefore, for atrial fibrillation, it has to be anticoagulant. For the last 50 years, we used to give rat poison called warfarin. But over the last 10 years, we have better drugs. It's called direct oral anticoagulants. There are 4 in the market at the moment in Malaysia. The first one is called dabigatran or Pradaxa. The second one is called rivaroxaban or Xarelto. The third one is apixaban or Eliquis. And the latest one in the market is called edoxaban, or I don't remember the name, but it's edoxaban. The scientific name is edoxaban. It's quite new. All these are the same. So the first thing we do is risk assessment, modify risk factors, hypertension treat, diabetes treat, put the patient on a weight reduction program, alcohol stop, and then put the patient on blood thinner, and then we talk about how do we treat this fast heartbeat. We can either take medications, and then we will tell the patient medications pros and cons. If I tell the patient with diabetes, who has been having diabetes for the last 20 years, sir, I have a cure for diabetes. That means if I were to give you this cure, you don't need to take diabetic medication for the rest of your life. What would you say? The patient say, of course, doctor, I don't want to take this medication. I cannot eat ABC. I cannot eat chendol. I want to be cured from diabetes. For diabetes, unfortunately, no cure yet. For hypertension, unfortunately, no cure yet. But for atrial fibrillation, over the last 20 years, we've been working on ablation. So taking medication is good. If it works for you, it's good. And you don't have side effect from the medication, it's good. But if there is a cure, why not think about a cure? And the cure does not include open heart surgery. The cure is called catheter ablation, where we put needles and we just puncture with a needle in your leg, and we advance all these wires into your heart, and we map your heart, and we can then we can map and see where the area of short circuit is in your heart, and we fix the problem by using radio energy to like welding inside the heart. So that's called catheter ablation. Now, who should go for catheter ablation, who should not? Depends. If you are young and you are getting atrial fibrillation, do you want to take medication for the rest of your life? No, right? So you try to go for cure, because if we can get it right, then you be cured. You don't need to take medication for the rest of your life. So I think for younger patients, we should aim for ablation. But if you are 88 years old and above, probably, I'm not saying you shouldn't go for ablation, but we will then discuss with you about pros and cons, because at your age, the risk is a bit higher. You may just be okay with medications because your expectations may be not as high. But again, I don't want to be biased. I have patients who are 90 years old and says, when can I play golf? I already booked tickets to go to Melbourne, in Japan to play golf. So who am I to say, oh no sir, you are 90 years old, just stay at home, watch Netflix. No, if you feel that you want the best out of your life and it cannot be achieved with medical therapy, we will sit down with you and talk to you about what are the risks involved, and if both of us agree, we'll proceed with ablation. For us, age is not a problem. Medically, we look at age in two. One is the age that you're born with. It's called chronological age. You may be 80 years old, but you are healthier than a 50-year-old. So we call it biological age. You may be 60. Chronologically, you were born in the 1920s, 1930s, so now you are 70, 80 years old, right? But you are still able to run half marathon, go to the gym, carry weight, deadlift 200 kilogram. You are better than a 50 years old. So for us, as physicians, we look at biological age and not chronological age. So that's very important for those of you when you see your doctor. Okay, so number 11. If my heart rhythms returns to normal, can I stop taking AF ablation? A lot of patients ask me this question. Very important question. Now the answer is this. If you are below 65 and you have zero risk for stroke, then after your heart return to normal, you may stop the blood thinners, not the rest of the medication. If you had gone for ablation and after the ablation you no longer have atrial fibrillation, and we must make sure that we have daily evidence of no AF, which means not enough. You come to see me once a month and I do ECG and say, oh, no AF. What about the 29 days that you didn't see me, right? So that's why the smartwatches become important. I always advise my patient, after ablation, get yourself at least a smartwatch or at least a blood pressure monitor or pulse oximeter and record it. If you tell me the next 6 months to 1 year, not a single day the AF comes back, and I prove it by recording at home, and I confirm it by a few tests that I do when you see me, ECG, Holter monitoring, then we'll sit down and talk to you and say, your risk for stroke is pretty low. I think it's safe for you to stop the medication. However, the minute the AF comes back, please restart back your medication. So this is very important. So usually the answer is, if my heart rhythm returns to normal, if it's by medication, then you cannot stop because you have not been cured. Your heart rhythm was just controlled with medication. But if you undergo a procedure and the procedure works and it's durable, it maintains, you are in normal sinus rhythm for the next 1 year, that means that you are probably lucky and you're probably cured from your arrhythmia, especially if you are young. If you are above 65, I would advise continue the medication because the AF may just come back even though you've been lucky for the last 1 or 2 years. The year 3, year 4, the possibility of AF come back because we are getting older and older. Is there any form of exercise the AF patient should avoid? Generally, we do not have any specific advice that you cannot do this exercise if you have AF. If your AF is well controlled, for example, and you are able to do exercises, I always tell the patient, if you can, look at your heart rate, adjust your heart rate. You all know about the maximum heart rate, right? So you know your 220 minus your age. So that's a rough guide. So for example, if you are 70 years old, 220 minus 70 is about 150, right? So we said that is your maximum heart rate. If you want to do exercise and you have a heart problem, do not achieve 100%. You go for, maybe you start exercising, aim for 70%, build up to 80%, 85%, and stop there. So, but don't be too strict on this, because I have, sometimes I go exercise with my colleagues and I say, hey, why do you stop? Oh, because my heart rate has achieved, I've already achieved 100% heart rate. If you are a healthy young guy, the maximum heart rate is just to inform you that if you are going on a 100-kilometer bicycle ride or marathon run, if you reach your maximum heart rate in the first 10 kilometers, you probably will not make it the next 90 kilometers. That's what it means. So you pace yourself because you have to save your energy. But if you have a heart problem, then you want to try and not achieve 100% because you want to protect your heart. So you don't want to sort of stress your heart too much. So yes, you can do any form of exercise as long as you are okay. You don't push yourself even though you feel breathless or your heart rate is so fast and then it triggers AF and you still continue playing badminton, smashing here and there, going on a 200-kilometer ride or running a half marathon even. So you got to know yourself and you have to pace yourself. So in general, exercise is not an issue, but you have to know from your own fitness level and build up to that. I regularly exercise. The next question is, I regularly exercise, but recently I find myself very out of breath after 15 minutes. Is this symptom of AF? Could be, or could be that you're just not very fit. So, as I said, if you think you have AF because you're out of breath after 15 minutes, then what you do is you should feel your pulse. If your pulse is very fast, unusual. For example, let me give you an example. Let's say you're a badminton player, and you usually you play 1 hour of badminton, 5 sets, for example. So I don't play badminton. Maybe 5 sets, not within 1 hour. But let's say you're used to it. Actually, after 15 minutes, my heart rate usually is about 120, 130. Now suddenly it goes to 170. So what I'm trying to say is, when you think your heart rate is fast, have some form of measurement. Don't just say, I feel my heart rate fast. Because nowadays it's so easy. You don't even have to have a smartwatch. Even the heart rate monitor like Fitbit, it can tell you that suddenly you said, I was playing badminton, the first 10 minutes, my heart rate was 120, 130, suddenly it went up to 200. That is abnormal. So which means that if you find that suddenly your heartbeat goes fast, there is a possibility, I'm not saying it's AF, possibility that there is some irregular heart rhythm or abnormal heart rhythm. So you need to try and detect it more accurately. And if it is atrial fibrillation, then yes, then you need to come for treatment. So I will answer question number 3 is atrial, because this is the first time that people are asking me about atrial flutter, right? So we talk about atrial fibrillation. Well, what is atrial flutter? When I see a patient with atrial flutter, I tell the patient there is a typo, big brother, called atrial fibrillation somewhere behind. What is atrial fibrillation and what is atrial flutter? Atrial fibrillation is total chaos. Imagine in your heart 5 tornadoes spinning around. 5 tornadoes, huh? Tornadoes, what do you call in Malaysia? Tornadoes is, we don't see tornadoes in Malaysia lah kan. We see these tornadoes usually is in America lah. You know, like tornadoes, the Malays call it puting beliung. Okay, 5. That's atrial fibrillation. Total chaos. Or sometimes politically incorrect, I tell the patient 5 terrorist group in the country. Atrial flutter means only 1. More organized. Not as dangerous, but more difficult to treat. So sometimes the patient has got, at time, total chaos. 5 tornadoes. Atrial fibrillation. The heartbeat is irregular. Irregular. Very fast and irregular. You go boop, 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 like that. Atrial flutter, the heart rate is consistent but fast at 150 beats per minute. If you feel your heartbeat at 150 beats per minute consistently, it never varies, it's probably atrial flutter. Atrial flutter, the upper chamber, the atrium is beating at 300 beats per minute. So why is your heartbeat 150? Because God has given us a protection. It's called the AV node. The cable, the electrical cable that connects the upper chamber to the lower chamber is called the AV node. That cable saves your life. Otherwise, every time you get flutter or fibrillation, you will die. Because nobody can live at the rate of 300 beats per minute pulse or 400 and 500. Atrial fibrillation, the upper chamber is beating at between 400 to 800 beats per minute. Atrial flutter is 300 beats per minute. But your heart rate is not 300 beats per minute. Your heart rate is 150. Why? 300 divided by 2. What does it mean? For every 2 electrical impulse that arrive at the AV node, 1 get turned away and 1 it's like you go to Singapore, Causeway from Johor. 2 cars arrive at the Singapore custom, 1 out and 1 allowed to go. So which means 2 cars arrive, only 1 is allowed to go through. So 300 arrive, half is removed, only half comes down to your heart. Your pulse rate is 150. Atrial fibrillation 400 to 600, the AV node even work harder. It only allow for every 4 or 5, only 1 to go. So from 400 to 600 to 800, your heart rate is about 120, 130, 140, right? So is atrial flutter life-threatening? In general, it is, if it is in the young, the atrial flutter is not life-threatening. There are less risk of fibrillation, of stroke for atrial flutter. But in older people, as I said, the atrial flutter usually comes with a partner, and the partner is atrial fibrillation. So if we see a patient with atrial flutter, we treat the patient as if he has the same risk for stroke as atrial fibrillation and start the patient on anticoagulant. The difference, however, in terms of how to control this flutter versus fibrillation. Fibrillation is more easier to treat with drugs. But flutter, when it comes, drugs doesn't work. So we either cardiovert you, put electrical shock and get the flutter out of it. That's only temporary. Or the best treatment for flutter is catheter ablation. The chance of a cure for flutter is 95%, much higher than fibrillation. But if you have both atrial fibrillation and atrial flutter, and when we know this beforehand, we will do both fibrillation ablation and flutter ablation at the same time. Okay, so Ivan is asleep now, and his computer is also asleep. Right. So where are we now, Ivan? Number 4. What is the treatment for AF? I think I have mentioned that at great length, right? I talk about make sure that you treat for stroke, make sure that you control the rate, make sure that the patient don't get a heart failure and all that. Maybe, how long more do I have? Oh, 10 more minutes. Okay, so 10 more minutes. So maybe I will answer now a few more questions. This is a very long question. Last year, I was told by my dentist I am one or two out of maybe 100 patients who have reaction to dental anesthesia. I think maybe dental anesthesia is just a local anesthetic. I had heart palpitations soon after injection, waited for flutters to subside, what seems like 10 minutes, then the doctor continued his treatment. Happens thrice. First time more than 10 years ago, and then last year 2 times chronic. Does heart palpitation means I have adverse reactions? Okay. Very difficult to answer that question because when you go to the dentist, usually the dentist gives local anesthetic. It's called lignocaine. Sometimes we do have reactions to lignocaine. Can you not move the thing? Okay. So sometimes patients do have a reaction to lignocaine. And if you have the first time a reaction to lignocaine, you have to tell the doctor because then it could be more of an allergic reaction to the lignocaine rather than lignocaine causes the palpitation. However, sometimes when we give local anesthetic, we make sure that the local anesthetic does not enter into a blood vessel. So when you see the doctor, usually we aspirate, make sure that the needle is not in the vein, and then we inject the local anesthesia. But what happens if the anesthesia, local anesthetic drug, enters the vein? Then you get lignocaine toxicity. That can cause the palpitation. So palpitation can either be because the drug is accidentally injected into a vein, or number 2, the drug is overdosed. So there is a limit to how much anesthesia you can give. And I think usually dentists, they give not much, but sometimes you give too much because it has to be based on your weight. If you give beyond what you're capable of, again, you can get lignocaine toxicity. So I'm not sure whether what you have, the heart palpitation, was due to those conditions, or you have atrial fibrillation or atrial flutter, and that was triggered by the so it's difficult to say. So I think what you should do is the next time you go to the dentist, you may want to wear a smartwatch so that you can detect whether it's atrial fibrillation or not the next time you have the palpitation. Okay, so which other form of question? I had a pacemaker implanted by Dr. Razali in IGN. I presume it's me. I left IGN in 2017, so this was in November 2010. In October 2022, during my checkup, it was found that my heartbeat too fast at rest, and I was asked to do a Holter in December, and I was told that the fast heartbeat is not too frequent and just short interval, so no need procedure or blood thinning. Lately, I feel breathless during a trip to Switzerland, Italy. When climbing up the stairs or over the ground, do I need to go for tests? Now, the interesting thing is, if you have a pacemaker, and if you have a dual chamber pacemaker, which means you have 2 wires up, one in the atrium and one in the ventricle, the pacemaker will be able to tell you whether you have atrial fibrillation or not. That's very important. So patients who have pacemaker and they go for procedure, I love it, because the pacemaker will tell me whether what I've done is good or not. Because before the pacemaker, it will tell me the burden. You know what it means? Means that The patient will tell me that the patient, since his last visit to see you, I have collected 10 atrial fibrillation episodes lasting from few minutes to few hours. It gives you the time and the day. And I'll ask the patient, on the 26th of March 2023 at 10 p.m., did you feel anything? The physician said, no. Well, I said, well, your pacemaker detected, and I confirm it, that it is atrial fibrillation, and it lasted for about 10 hours. After the treatment, then I can use the pacemaker to tell the difference that for the last 1 year, not a single AF episode. So your question is, yes, when the doctor did the Holter, if the atrial fibrillation that is detected by the pacemaker and is not felt by the patient, is called device-detected atrial fibrillation. It's a different subject altogether. The question is, people are now questioning what is significant. And some people use the old criteria of 6 minutes. If you have atrial fibrillation 6 minutes or more, then you will be on an anticoagulation. If your atrial fibrillation, like the doctor says, is too short, maybe a few seconds, less than 6 minutes, that's what he means by saying that at this moment, you don't need it. But if you feel breathless, then your next appointment, they will tell you, sir, your atrial fibrillation now is no longer a few seconds or 1 or 2 minutes. It's not getting longer. So again, if you are 65 and above, I will recommend that you take anticoagulation, because you may be a few seconds 3 months ago, but you may be starting to go more than 6 minutes, more than a few hours at the end of 3 to 6 months. So therefore, you don't want to get a stroke. So I would certainly go and see your doctor and ask for an early appointment, because you're beginning to feel more symptoms which could be related to worsening or higher frequency and higher burden of atrial fibrillation. Why is a healthy person, atrial fibrillation is the same as supraventricular, you know what the difference? Okay, the word supraventricular tachycardia is a general term, of which atrial fibrillation is part of it. I always tell the patient this: if I say, do you have a car? And the answer is yes, means you have supraventricular tachycardia. I've not asked you what car you have. Atrial fibrillation means I ask you what car you have. So under supraventricular tachycardia, it could be sinus tachycardia, it could be AV node reentrant tachycardia, it could be atrial reciprocating tachycardia, it could be focal atrial tachycardia, it could be atrial flutter, it could be atrial fibrillation. So all these are under a supraventricular tachycardia. However, traditionally, when we talk amongst ourselves, supraventricular tachycardia, we mean two things: AV node reentrant tachycardia and the AV reciprocating tachycardia, AVRT, due to accessory pathway. So supraventricular tachycardia does not lead to stroke. It is easily fixed. Usually patients are born with extra wire. The treatment is radiofrequency ablation, because this has got a 99% cure rate. And this supraventricular tachycardia, unlike atrial fibrillation, occurs in younger patients. Now, you don't want to give a 15-year-old person medication for the rest of his or her life, right? This is an easy fix, 1 hour job. We go in through the leg, patient is sedated, 1 hour, done. Patient does not see you anymore for the rest of his life until he reaches 65, and then he gets atrial fibrillation. So SVT, fixed cure, very high success rate, and the risk is actually negligible. So if you have supraventricular tachycardia, I would recommend go for catheter ablation. Don't take medication. Can acid reflux cause irregular heartbeats? It's interesting, because a lot of my patients with atrial fibrillation, there's a very close connection between the heart and the stomach. So whenever they have atrial fibrillation, they feel kembung, they feel good. And similarly, when they have a lot of stomach distension, a lot of gas, it also triggers the atrial fibrillation. Yes, the answer is yes. In fact, after I do my AF ablation, I always give the patient proton pump inhibitor because of acid reflux. Because the ablation, the heart is very close to your esophagus, and there are nerves that runs along the esophagus, which is which supplies the sphincter. So when we do ablation, or when there is sudden dilatation of the left atrium, it does trigger this nerve, and it may cause a reflux. So there is a very close relationship between atrial fibrillation, anything in the heart, and reflux. How does atrial fibrillation lead to heart failure? Very, very good question. Yes, if you have atrial fibrillation and the heart rate is not controlled. Meaning that your atrial fibrillation is not 2-3 minutes once a year. That one, no heart failure. But if you have atrial fibrillation all the time, it's called persistent atrial fibrillation, and the rate is above 120 all the time. And who are those people? No symptom. So they don't know, right? So they are doing their normal work, they do the exercises, and their resting heart rate is 120. So when they exercise, they go to 170, 180. Over time, this can lead to heart failure. This is called tachycardia-induced heart failure. The beauty about this heart failure is that it is reversible. If you have a heart attack and you have heart failure, too late. Nothing will change this. Your heart function will not improve, even after angioplasty, unless it's stunning. All this medication we give is to prevent it from getting worse heart failure. But atrial fibrillation causing heart failure, if there's no other cause, you treat the atrial fibrillation, the heart failure improves back to normal. Even with pacemaker, we can get AF. It's nothing to do with the pacemaker. There are patients who have what we call sick sinus syndrome, triple S, SSS, or tachycardia syndrome, meaning that they have atrial fibrillation, and then the atrial fibrillation stops, and the heart stops for a few seconds, and they faint. So the patient needs a pacemaker for this group of patient, but the pacemaker only tackles the slow heartbeat. You need them to tackle the fast heartbeat. So again, what my approach to patients with both fast and slow is, I look at the patient. If the patient is young, I try to avoid pacemaker and fix the primary problem, because if I can prove that the slow is related to the fast, if I fix the fast, the slow will not come. But there are some older patients, they have both fast and the slow is unrelated to the fast, meaning that even if I tackle the atrial fibrillation, they will still need a pacemaker. So for this group of patients, I will put the pacemaker first, prevent the patient from fainting, because it's very dangerous in old people when you faint, and then try to control the atrial fibrillation with drugs. If I fail, then I tell the patient, be prepared. You may need both pacemaker and then get a catheter ablation later on if the drugs fail. So some patients need both. Sometimes I fix the AF first, and later on they still faint because they have slow heartbeat. So they need to have both both ablation and pacemaker. Not very common, but the question is, even with pacemaker we can get AF. Is as if the pacemaker causing AF? No, the answer is no. It is because the patient already, before the pacemaker, has got both this condition. Okay, so the pacemaker will not prevent AF. The pacemaker will only prevent you from getting a slow heartbeat and prevent you from getting fainting. Good evening, doctor. Ablation, ICD, which one is better? So the question is, I presume you're not asking me about AF ablation, because AF, if you talk about AF ablation, it's got nothing to do with the ICD. So ICD is for patients with at risk for sudden cardiac death, cardiac arrest. So for that, we implant the ICD, which means implantable cardiovascular defibrillator. It's like a pacemaker, but it has the ability to give you electrical shock to jumpstart your heart. So atrial fibrillation doesn't lead to cardiac arrest. So if I have a patient who has got high risk for cardiac arrest, I put in ICD, but this patient also may develop atrial fibrillation, so it's got nothing to do. So some patient I put ICD, and then we monitor the patient, because the ICD is like a pacemaker. It also collects information, and I say, hey, you have a lot of AF, and this AF is not good for you, because it might cause the ICD to shock you unnecessarily. So we do catheter ablation for this group of patient, and it's not one is better than the other. They are two separate conditions. Next question, condition Wolff-Parkinson-White related to AF. Wolff-Parkinson-White, you are born with an extra wire. Okay, Wolff-Parkinson-White. Wolff-Parkinson-White is the only SVT. I forgot to say Wolff-Parkinson-White just now. I say SVT, right? Many cars. So Wolff-Parkinson-White, if you have Wolff-Parkinson-White and you have AF, then it can lead to a dangerous condition. So patient with SVT usually do not get cardiac arrest. But if you have Wolff-Parkinson-White, there is a small risk of cardiac arrest, usually more in children. So when you have Wolff-Parkinson-White, my advice is get it treated. And the best treatment is catheter ablation, 99% chance of cure, and you are cured for the rest of your life, and you do not risk cardiac arrest, even though the risk may be small. Why should you take a risk in a 15-year-old boy with Wolff-Parkinson-White, even though if I tell you the risk is 1%? Are you willing to take the risk for your child, even if it's 1% cardiac arrest? No. Get it treated, because it's easily treatable, easily cured. by a simple procedure which is only 1 hour, 2 nights stay in the hospital, and they don't see doctors for the rest of their life. So, with that, I was told, ending speech, bye-bye. So, I hope that you guys enjoyed this Facebook Live. This is my second one. I did one about 2 years ago. Let us know at CVSKL Facebook if this is something that is beneficial, then we'll do more of this in the future. If not, I wish you a good evening. Thank you for joining us, even though it's in the evening. I hope you have a good evening the rest of the day, and for the Muslims, enjoy the best 10 days of the year of Zulhijjah.